And we're back for round 3 with Mehmet Cem. We were just discussing how long it's been since the first episode, which if people haven't listened, there's been 2 prior E3 episodes with you. One was a solo recording with Mark, and then the second was with Chris Rayner. I know the first episode was episode 44. I have to go back and check the other. But for people who may not have listened to those first 2, Mehmet, can you just give an intro on yourself?
Yeah, thank you. Well, look, firstly, thanks for having me back for the 3rd time. I feel like that's some sort of like graced land for someone to come back to E3 podcast 3 times. So I appreciate you having me. If people are listening and have not heard the first 2, I do question what podcast they are listening to if they haven't listened to the first 2. But just a brief summary of who I am. So my name is Mehmet Cem. I'm a physio from the UK. Been a physio for about 15 years and specialised in hip, pelvic and groin pain for pretty much the last 12 years. Also, in particular with kind of like hip joint conditions like FAI syndrome and hip dysplasia. And I pretty much have I was just saying to you, Chris, before, I have a pretty mixed week. So I kind of work in primary care, which is alongside kind of frontline, like general practitioner doctors in a physio role there. I work in management. I have a course that I teach around the world. And I do the social media stuff. So I've got quite a busy work life, and then I've got a wife and 2 kids. So I've got a busy out of work life, and but I can't complain. Life's good. I feel blessed, and looking forward to talking to you now about this topic, which is really passion of mine, and also something that I think we need to certainly get into the forefront of some clinicians' minds. And also, I've found patients often listen to these podcasts and find them really helpful from an educational perspective. So I'm going to consider that. And whoever's listening to it, say hello and good luck and enjoy it, and hope you survive the whole podcast.
Yeah, I reached out to you earlier this week based off of a post that you recently had come out on Instagram, and it was on hip dysplasia. And this doesn't really seem to be a topic that's discussed a ton on podcasts, or at least I haven't listened to multiple episodes on this topic. And you had mentioned before our conversation, it's not as sexy as something like, FAI or labral tears, or as common as potentially total hip replacements. So it seems to be kind of like hidden in some of this hip world. But you, in the post, and you can elaborate on it if you want, but you alluded to this recent paper by Evans et al., and we'll dive into that. But the whole realm of hip dysplasia, it needs to be in someone's mind through an examination and deciding if this is a likely diagnosis. Where do we go from here? So that's what the conversation is going to be today. Can we just start with a definition? What is hip dysplasia?
Yeah, for sure. And I think that always helps. I think like just kind of stripping it back and just going through like the fundamentals of like the basics. Let's kind of talk about the basics, because I think that's where patients get confused and clinicians get a bit anxious about it when they hear like terminologies and jargon. So let's kind of break it down. Basically, you've got a hip joint, right? It's a ball and socket. And essentially that ball is covered, not completely by the socket, otherwise obviously wouldn't move. There's a percentage of the ball in the socket that is covered. That is a normal hip, right? Now with hip dysplasia, essentially it's where the coverage isn't as covered as it should be. So there's kind of like a slight deficit in where it would cover the ball in the socket. You could refer to it as a shallow socket, essentially. Now, there are a varying level of severities to that. Some people have barely any coverage at all, and others have very subtle under coverage. And this is the whole kind of, I guess, like the ambiguity and the difficulty in managing someone with hip dysplasia is the vast level of how much it can vary from severe to hardly at all a problem, but still there. So essentially, we've got ball and socket, and a socket that is possibly slightly shallower. That is essentially what hip dysplasia is. Now, what's really kind of like important to consider is that loads of people throughout the world will have elements of hip dysplasia. They'll be fine. It doesn't mean hip dysplasia as a morphology, as a skeletal type of hip makeup doesn't equate to bad, painful hip that needs surgery. Like, it's really important to consider that people have elements and levels of it that they can manage quite well, and it's important to consider that, especially when you do have someone with hip pain, so you don't disregard how effective physio can be to manage their symptoms. Now, in regards to the types of hip dysplasia, the important thing to consider here is if we refer to hip dysplasia as a total entity, it tends to kind of come to light or develop into two situations. So if we've got a ball and socket, then you've got to think about, well, firstly, when does that ball and socket develop? Well, you're not born with a fully matured adult hip, right? You kind of are born and then things develop. And over a period of time, your skeleton will mature. Now, during infancy, there's a particular stage where things develop and they grow, and that's how infants become toddlers and whatnot. Now, there are certain situations that could lead to hip dysplasia developing at that age in infancy, at birth, and that's why there's so much screening around hip dysplasia in utero, in family histories, and all that stuff that we'll touch on. And then it can develop in young adulthood or in adolescence, so like an adolescent onset, because there is secondary ossification, or basically further development that happens at that age. Because when you get into like later teens, male or female, bones start to get to their maximum level of development. So there's a situation that occurs where things are kind of like changing again. So it might be at that stage where the coverage or the socket doesn't fully form. And I think what's really important is this socket, right? So you've got a ball and socket. The socket doesn't just, it's not like one thing. It's almost like, think of like a jigsaw, like three bits of a jigsaw that like come together and then they develop and grow and they form the socket. They kind of fuse. And sometimes you might have one bit of the jigsaw that doesn't completely fully develop. And that sometimes leads to that subtle under coverage. That might mean there might be like 10% part of it not doing its job. And that's where the kind of difficulty and the confusion comes into hip dysplasia. Obviously, you have some who just don't have that development at all. And that's where things kind of become a little bit more apparent and people suffer with like instability of the joint. And that instability is essentially the problem that we're trying to manage. So hopefully that's it in a nutshell. I'm trying to kind of like, don't want to kind of bore people too much with the science jargon, but it's good to know the kind of absolute fundamentals of what it is as a hip condition that we see.
Yeah, I appreciate you providing that caveat early on of there's a spectrum of the severity of dysplasia and just the morphology of the hip and the nature of how symptomatic it is. And people can have no symptoms or minimal symptoms and not have to have this be a significant disruption in their life, like a lot of these other conditions. So from there, you had mentioned in your post, for people that do have symptomatic hip dysplasia, it's commonly misdiagnosed and it takes a long time for this true diagnosis to come about. Do you know why that's the case? What are the reasons as to why this misdiagnosis is so common?
Look, I've got a feeling that I know. It's hard for me to say kind of worldwide I know the answer to all of these things as to like why everyone, because it's not the case. Some people get a diagnosis quite quickly. I think a lot of it comes down to, probably I'd say you can kind of nail it down to a few points. Firstly, it depends on if you're a patient presenting in a certain way and you're starting to get symptoms and it is because of hip dysplasia, you have to essentially present to someone who will have this on their radar to even consider it as a possibility to why you have hip pain. So if someone comes to see me, right, and they've got pain in the middle of their hand, the base of their fourth finger or whatever, you come to me asking me for a specific insight into the nitty-gritty of the hand anatomy, I tell you now, I couldn't be more worse placed to support that patient. I'd have no clue. I'd be like, I don't know, it's a bit stiff, your hand hurts, I don't know, it's a tendon. Now think about that for the hip. If you go and see someone with this hip pain and the symptoms and the signs and the presentation can really overlap and just have a myriad of presentations that could mimic and be blamed on a whole other kind of muscle group or joint pathology or whatever. If you're not seeing the right person, one, with good intentions, they might miss it because they're not exposed to it. They don't have the experience. They don't think about it. They haven't seen it recently. When I do my course and I teach, I openly ask the class and wherever it is, and I say, look, we're going to go through hip dysplasia now. Show of hands of how many of you have seen someone with hip dysplasia in the last 6 months. In a group of 30, maybe one will put their hand up and they'll say, I've seen it once this year. Now, if I say put your hands up of how many people who have seen hip flexor tightness or OA or FAI, most of them put their hands up. I'm like, look, I guarantee you have seen someone with hip dysplasia. You just haven't known what it is because of various factors. So I think exposure, experience, and knowledge plays a key in identifying that. Unfortunately, sometimes that also transfers into non-physio inputs. So if you're seeing someone who's an orthopedic consultant, surgeon, or had imaging, unfortunately things do slip through the net. And from an imaging perspective, depending on the type of imaging that you've had and the person that you've seen who's assessed it, that can also mean that things slip through the net. So you have someone who's gone for scans and x-rays or whatever, and they're being told, oh no, there's nothing there. But there might still be something there. It just hasn't been picked up, So same with us, right? We're MSK clinicians. If someone came to us, right, hopefully this doesn't happen to you, Chris, right? But let's say, for example, you're on the street and someone screams out for a respiratory physio to come and suction their phlegm. Never happens, right? But imagine in that scenario, you wouldn't be best placed to go and do that. Now, from an imaging perspective, there are also like specialists who are better MSK radiologists are assessing x-rays and scans and whatnot as well. So I think, again, it comes down to the same principles: knowledge, awareness, exposure, understanding of the condition. And unfortunately, that plays a big role. The other factor is the way that the symptoms, I touched on this before, really masquerade, overlap, interchange with how they present. And the fact that this can coexist with other hip conditions as well, and extra articular hip conditions, making it really difficult to nail down, like, specifically what is the primary driver to these symptoms and what is a symptom in itself. Do you see what I mean? So I think all of these things make up like a perfect storm as to why, unfortunately, sometimes the diagnosis is delayed, unfortunately.
Well, let's go straight into this differential that you're thinking through and the mnemonic from Evans et al. To help clinicians better identify what are the subjective and descriptive elements and the objective exam elements that would lead us towards a probable diagnosis and potential kind of referral to other providers for potentially imaging on hip dysplasia. So I'll let you take it from here if you want to go straight into the mnemonic, or what you want to start with from someone's coming to the clinic and a clinician is starting to think through, okay, what would lead me to believe this is potentially hip dysplasia?
Love that. All right, I will dive in. I'm going to take your off and dive right in. So this is really, so the Evans study that was published was great, because I think the more studies like this that come about that really help direct a clinician's thought process is vital. Because often we have so much research that's published that says this doesn't work, or this is missing, or we need more data for this. And essentially what we have with this new Evans study is they went and did a survey, a 2-part survey for people who have had hip dysplasia, to really understand what they struggled with, their signs and symptoms, their presentation, the mnemonic that we'll touch on shortly. So all these things that can guide clinical practice. Then there's one thing for me that stands almost like at the very pinnacle when I'm thinking about, like, could this be in my differential? I call it like a hypothesis battle. When my patients walked in, I'm thinking, what could it be? Who's gonna win the Royal Rumble of the hypotheses, right? Because we can't get a diagnosis. It's too tricky in clinical practice, because you need loads of other things to get the full diagnosis. So we've got a hypothesis battle going on. Now, in this situation, I'm trying to think, right, I'm looking at this study and there were 92 participants. I think it was 92. Like, I read it like 3 times. So I need to it might be slightly less, but 92 participants who responded to these surveys for this study. 2 were male, 1 was transgender, right? So the majority were female. That's not a coincidence. There is such a high prevalence in the female population. Never exclusive. Those 2 male patients there are kind of like key, like kind of reminders that it's never 100%, but it makes up the vast majority. And then we've got a young adult population. So we've got like young adult female population, and historically past research has also shown a very high prevalence towards Caucasians as well. So you have, and I'm talking like 80 to 90%. That's high. And if you're talking about 80, 90% females, 80, 90% Caucasians, and of similar age in the in a young adult population, you're then thinking like, how on earth, when someone comes in with hip pain, can I not have that at the top of my radar? And it's almost like I need to know that it's not that until I'm proven otherwise, because it makes up such a vast majority. Now, what I don't want you to do is think any person who walks through the door now who fits the bill is just going to be diagnosed and labelled as hip dysplasia. Far from it. But this demonstrates how common it is, and it's really important because ultimately hip dysplasia is a risk factor for arthritis. And arthritis is something that we really need to identify and really kind of like get on top of as quick as possible. Now, all I've said to you so far is the kind of person and the demographic. I've not said anything. They've not even spoken to me yet. All they've done is walk through the door and I've seen their date of birth. That's already putting that little seed of, it could be, let me just look into this further. And now what the mnemonic does is it helps us identify some of the common subjective cues and objective cues that the patients will tell us that I think are really key. Now, so it was alpha, the mnemonic was alpha, so ALPHA. Now, each one of those things kind of categorizes some really important key points. So age, we mentioned there, so kind of, young adolescent or young adult. And then we've also mentioned from a female perspective. So we're kind of like, it sets the precedent of who it is that we're potentially talking about. The L is in regards to a limp. Now, this could vary because you could have a painful limp because you've had it for so long. So you could have a leg length difference if there's a severe level of hip dysplasia there. Also, if you have someone who has that level of hip pain and muscle deconditioning and weakness, you can get altered gait patterns like Trendelenburg and things like that. So essentially, we've got L as the limp. Then we've got P, right? So you have to have someone who has pain, because I said to people have elements of hip dysplasia and they're fine. You have gymnasts, contortionists, like ballet dancers, many of whom may have elements of hip dysplasia that they require for their sport, but they can tolerate. That doesn't mean that they're a patient, that's just like their makeup. So we need the P, we need the pain. And often the pain isn't just like, I didn't have anything on Monday and then on Wednesday I'm in severe pain. There's a story there, right? There's a story, there's a narrative, there's a history. This is where we need to listen to patients, right? Because they'll start to paint the picture. They'll tell you the answers, right? They're telling us, I've always, felt something there historically. It's maybe been a bit stiff, or I found certain positions to be uncomfortable. And then what happens is the clinical picture changes. So they go from being able to tolerate things quite effectively to then finding things like deep flexion or squatting or crouching, like really kind of loading of the joint, to become intolerable. And then that has a knock-on effect to just functionally what they can do. So then all of a sudden sitting hurts or driving hurts. And whereas before it was like, I couldn't run that fifth kilometer, but now actually just sitting hurts all the time. I've got quite like a severe intolerance. So, and that takes time. It could be over a year. That's not going to be like in a week. So even at that point, the narrative is telling me like the time also is key here. The time of onset, the time of symptoms, and the progression. That's giving us a lot of information. Then we come to history. Now, whoever's listening to me, you're doing well to listen to this monologue from me. So just bear with me here. This bit's important. So then we've got H and we've got A. So we've got history. Now, the history is twofold. One, we want to know if that person's had an individual history of their own hip dysplasia from infancy. So was it treated? Was it not treated? Is there any history there? Equally, many patients, right, if you say to them, did you have any history of hip dysplasia when you were young, might look at you and think, honestly, Mehmet, I don't even know what you're saying right now. I've never heard of those words before, right? And you think, okay, fair, because you wouldn't have. So then you've got to dive into it. And you're like, have you got any siblings, relatives, parents, anyone who's had hip dysplasia or hip problems? Now, if you're lucky, they might turn around and give you the absolute, golden answer. Yeah, family history, mother or father, and you just know it. Or they might say, no, but, my mum or my dad's had some hip problems, but they're, they're older. I'm like, okay, so what do you mean? Well, like my dad has his hip replaced, or my mum had her hip replaced, but, they're older. And I'm thinking, all right, fine. You could disregard that completely. But then you're thinking, well, hypothetically, if you're a young adult in your 20s with hip pain and you're telling me your parents had a hip replacement, your parent really, on average, is probably going to be what, 50, 55? They're having a hip replacement at that age. They probably just didn't have hip pain that week. They probably had it for a while before. And then we're talking hip replacement 2 decades off the common. So then you're thinking, well, was there something there and it hadn't been picked up? But there is a family history there of something. And then the last one, A, is referred to as articulation. And that is if you're having like popping hip, clicking hip, snapping hip, or positions of discomfort. Like, so if someone's kind of having to sit in a particular way, or they find that they're reporting that they always feel a bit hypermobile or super flexible. And I think those things are important to consider as well, but also not to fully hang your hat on the fact if someone's saying that they have hip dysplasia. We're having to consider all of these things. And this is why this study is great, because it's starting to give that new evidence-based guidance for the things that we can look out for. But the biggest important thing here for anyone listening is all of those points, they haven't been special clinical tests, they haven't been scans, they haven't been MRIs, they haven't been injections, because this is where we start to build a strong picture. It's a subjective, it's us listening, it's us asking the right questions. But you can't ask the right questions unless it's in your mind to ask them.
Yeah, thank you for clearly diving into that. And like you said, a lot of information can be gathered before you even start an objective exam. What are the things that you're trying to, let's say it's this similar age range, this adolescent, young adult, let's say maybe it's a female. There's certain elements that make you lean initially towards this is kind of in the front of my mind as a potential diagnosis. What are the other things that you're trying to potentially rule out with this similar age range and potential female population?
Well, where the difficulty comes in is that we've got a young adult with hip pain, right? Now, I mentioned to you before about the basics of it. We said ball and socket and a shallow socket, right? It's not the shallow socket that causes pain. It's the influence of the instability as a result of that shallow socket. Because if the joint isn't doing its job, the stuff around it has to do more. The stuff around it being ligaments. So obviously ligament connects bone to bone. So the ligaments will move in a certain range of movement, but will limit excessive range. Now, if your joint isn't doing its job, then after a period of time, that ligament's going to have to do too much. And after a period of time, it will stretch and it will become lax. It will become a little bit less robust to what is being put through. As that progresses, even at that point, one, the symptom could come from what's called the periarticulum, so the capsule. Commonly, the labrum, which is the lining of the hip socket that gives it the additional suction and stability, can sometimes fail and be compromised. It can tear and it becomes a little bit less tolerant to the load that it's put under. That is the thing, more often than not, that can hurt. Now, I'm caveating that with the fact that I could scan everyone listening to this podcast now, and 60% might have a labral tear and have no pain at all. But in a situation of someone who does have hip pain and they do have a labral tear, that's often the cause of where their symptoms are coming from, and then the cartilage surface secondary to that. So the thing that hurts, and I'm going to make it quite black and white here without kind of like provisos. The thing that hurts, the labrum. The cause of why that labrum hurts from hip dysplasia is the instability. FAI syndrome or hip impingement also is a condition that often hurts because of the labrum. So it's the labrum in that situation, if it's torn, that can be painful. So we have the same structure causing the pain, but two very different hip conditions, right? We've got one which is instability and we've got one which is impingement. The reason I'm telling you that is because both of them can coexist in the same hip. Now, this is going to make the situation even more complicated because they're not the same condition. They're very different in their nature. And the thing that we're still trying to treat is the same source. And that's the difficult problem, because when you said to me before, why do people sometimes have a degree of diagnostic delay? Well, it could be that they've got two conditions, condition A, condition B, A, hip dysplasia, B, hip impingement. They go and have an X-ray, the B has been picked up, the B has been treated, and the A hasn't even been identified yet. And actually, B being treated has made A worse if it is like invasive with surgery and things like that. So this is where things start to get, I love it because this is for me, this is what I'm passionate about, but also why I'm really critical when it comes to management and advice and guidance, and why I think often I get frustrated when patients are given advice without decent clinical reasoning. But unfortunately, clinical reasoning doesn't always exist on Instagram, TikTok, YouTube, unless you're E3 Rehab and the hip physio. But I'm biased, obviously.
Let's stick with that combination of these things can coexist, this impingement and this instability. How, as a clinician, do you navigate that? If you're, from the history, from some of the examination, from what they're telling you, you're thinking these two things are highly probable and there's a chance that they're both occurring. How do you then differentiate what's a bigger thing to focus on or to discuss or to move forward with?
I don't think you need to kind of exclusively, as a clinician, worry too much about separating them out and having a rehab plan that addresses one or the other. You won't be able to. They'll both kind of like intertwine. And often your rehab to assess, and so your rehab to address one will have some sort of kind of crossover to the other. Where it would be important from a rehab perspective to really be considerate of the two of the approaches, I should say, is the fact that actually for one hip condition like hip dysplasia, where there might be some laxity and instability, it's unlikely that that hip is going to be stiff. Like, you're talking about a laxity and an instability, which with it brings ranges of movement that aren't deficient. They're normally kind of excessive. On the other hand, with FAI, that's a hip that's usually does get a bit stiff, does get a bit restricted in certain ranges of movement. So on one hand, you've got one where you're having to kind of control range and strengthen through different planes of movement. And on the other one, you've got planes of movement that you'd probably struggle to navigate through because it hurts and because it's stiff. So I think when you're being patient-led and you're trying to kind of create a program that is bespoke, that's specific to this condition, there is going to be some overlap, but like, you're not going to be able to necessarily say this is just for one, this is just for the other. You'll just have to kind of be led by how the patient's symptoms are. What you certainly wouldn't want to do is freak out and think that like you can't manage it with physio, because just because these things are there now doesn't mean that they're not going to settle down with symptoms. We know well, now that symptoms doesn't necessarily correlate with severity and damage. And I think, unfortunately, that's easier said than done and managed if a patient hasn't had what the average time to diagnosis is 5 years of pain. Because in that period of time, sensitivity of pain increases, anxiety increases, stress increases. So trying to get patients on board and to manage it can be, quite challenging. So I think at that point, you just need to consider all bases. But from a rehab perspective, I'd say go with how your suspicions are. And don't be scared as a clinician. And also for patients listening, don't be scared for your clinician to demonstrate a level of ambiguity in regards to, like, if your clinician turns around and says to you, could be a bit of hip dysplasia, could be a bit of FAI, I'm not sure which one is the primary problem. I tell you what, that's usually the sign of an excellent clinician, someone who is aware of like the limitations that we have clinically. I think where my biggest concern is when I hear clinicians or trainers or whoever going, this is what you've got, this is why you've got it, this will fix it. It ain't that straightforward. I've been doing it for over a decade. Even I'm just like, could be a bit of this, could be a bit of that. But I'm aware of the others. And I think there's also a cutoff where if it's not improving, let's take a step back. Let's try and confirm the diagnosis now. Because up until that point, you've been working with a hypothesis. Unless you've got the diagnosis, obviously, before they come.
Yeah, so if they aren't coming with this diagnosis and imaging confirmed hip dysplasia, you do an examination, your suspicion is that it is hip dysplasia, is kind of the primary driver of their symptoms. What would make you decide to warrant imaging or to see, kind of have a second opinion or provider that may provide a true diagnosis of it, versus describing to the patient, this is kind of what I'm thinking is likely the diagnosis, or this makes sense with your clinical presentation. We're just going to move forward with rehab. What would be the instances where you kind of fast track to a second opinion or referral?
Yeah, I think that's a good question, because I think even with the best intentions, sometimes a rehab doesn't do its job, right? But also, there's two things here. One, you've got to give the rehab enough time, because if you've got someone who's had pain for years, like, it's not going to get better in 6 weeks. It'll take months for it to kind of get on top of. But also, what you don't want to have is someone who is seeing no net gain to their rehab over the months that you're with them. So you're not going to wait for like 10 months and then have no improvement and then go, actually, let's try and figure out what's going on now. You'd probably give it like 3 months. If you've seen nothing at all, then you, rather than delay it, just say, okay, let's just make sure we know what we're dealing with. I say the same for FAI syndrome as well. Like, you need to give it a bit of time. But if you've got a hip dysplasia patient where, rather than seeing progress, you're seeing a lot of flare-ups, exacerbations, regressions, you're giving them rehab exercises that really should be fairly low level that they're progressing with, but they're not. At that point, after a couple of sessions, even if it's the third session, you'd probably get an idea. Like, you probably think, look, I'm not getting anywhere. That's not necessarily in that situation. And if you've picked it up clinically and you've got a kind of a suspicion that that's what's going on, you're not necessarily not seeing an improvement because you've not just given them the right exercise just yet. Like, normally, if you do the right thing at the right time with the right management, you can see some net gain soon. It doesn't mean that it's immediate, but that net gain might just be that it's not as painful or they're not as incapacitated. Doesn't mean that they're back to normal, but that's still a net gain, right? But if you're in a net loss where it's just like regress, pain, flare up, more painkillers, those are the ones normally I would fast track. Or in an athlete, like, if it's their job, you don't really have as much time to waste. But in those situations, often they come having had everything in the world to diagnose it. From a diagnostic perspective, and I just kind of touch on this point a bit before we kind of move on, when you do have those patients who have maybe a bit of both, right, and we're talking about the structure, the labrum, that might be the thing that hurts for both, first we need to prove that thing is the thing that hurts, and usually a diagnostic injection would support that rationale. Now, if that pain goes with a diagnostic injection, I still don't know what's caused it, right? So I still don't know if it was the FAI or the hip dysplasia. Then at that point, to confirm or refute the level of severity from a hip dysplastic perspective, often like some sort of 3D CT imaging would be ideal, because then you can see, you take all the ifs and buts off the table, right? X-rays are great, but there is margin of error in regards to like who does it, who measures it, who assesses it. Like, movement analysis or augmented kind of 3D CT motion analysis can kind of take all that ambiguity off the table and tell you specifically if there is a structural instability, where is it coming from, how severe is it, and with the impingement, how severe is that, and is it going to be a factor to play? And that's when we start to really pull these things apart. There's a surgeon that I work with in the UK for some private clients called Damien Griffin, who's like really well known, but also I've done some recordings with him in the past, and his workup is so thorough. Like, it seems excessive from the outside because it's like X-ray, manipulation under anesthetic and sedation, CT analysis, movement, augmented like movement analysis, motion movement analysis. But all of that stuff does enough to warrant, like, if that person needs surgery, it's the right choice. And unfortunately, sometimes people fall into this like path of having surgery incorrectly for the wrong thing.
The paper discussed these individuals that have dysplasia. A lot of them are hypermobile locally at the hip or more broadly, and they have these hypermobile traits, or they have another diagnosis of EDS or something that would be systemically creating this hypermobile individual. And these people will lean towards sports that self-select people that are hypermobile, gymnastics, ballet, dance, etc. I'm sure this fits these younger females that are presenting to the clinic. A lot of them are presenting and doing those sports. How do you go about managing the interaction of rehab and a sport that inherently is getting them into these end range extreme positions? How do you go about that management and discussion process with the kid and their parents?
Yeah, look, I think depending on the age as well, I think it's, like you're saying, if they're younger and his parents involved, that's a little bit more sensitive. If you've got an young adult who's obviously independent, that also differs as well. I think, look, the fundamental thing here is what we don't want to do is start instilling fear. Like, what we actually want to do is the complete antithesis of that. You want to build physical and psychological resilience with your rehab. So jumping into saying like labels and terminologies and saying risk factors, I think we need to be super considerate of that, because even though with a lax joint from a dysplasia or whatever it might be, and we'll talk about this specifically, but if you have then like kind of activities that they're doing like ballet, gymnastics, or even if you've got, they love yoga, they're doing yoga, but it's flaring their hip up. The difficulty is that you also have people that do it and are fine. You also have people that on paper might have the same level of like hip morphology and are okay. So my thought with this is, what do they enjoy doing? Like, what is their quality of life around the sport and exercise that they do? Because I don't want to stop them doing it. And often where I would pitch this to the patient, because like when you're rehabbing someone for that long, it's essentially what you do have to do is you have to pitch it to them. You have to say, like, look, this is where we're at. This is what I expect of you. This is what I need of you for this amount of time. Let's figure out how you can stay compliant. You know, what's going to keep your adherence up. I know what I'd be like. I wouldn't be adherent if I just met someone and they were like, okay, stop doing this, stop doing that. And those are the things that I enjoy to do, even though you're thinking it's probably not the best thing for their hip. So what I would normally say is and I say this to patients pretty much verbatim. Like, I say, look, this is my proposal to you. Like, I know in order for us to get a suitable outcome from your rehab, what I need from you is maybe 3 days a week to do like a 20-minute circuit of these hip rehab exercises that I'm going to give you. Do you think you could do that? And if they say yes, then great. If they say no, then I'll try and figure out why. Like, is it because of time? Is it because you just hate physio? Do you just hate exercise or whatever? If they turn around and say yes, that's fine. And I say this, okay, so in that case, let's do that rehab for now as a starting point, alternate days, 3 days a week, and continue what you're doing. See how you respond. If it gets to a point where you're not seeing any, and let's talk about that net gain from rehab as well. If you're not seeing any gains, the only variable that I haven't controlled is what you're still doing. So for that, at that point, we might have to just limit that a little bit. So that's my nice way of saying we're going to cut it out, but I'll give them a little bit of a chance first to do it alongside what we're doing. But if you set the precedent from the beginning, then at that point, if it's not working, and you do take it out, month 2 or whatever, it doesn't seem like you're just throwing a kitchen sink and trying anything. It's like actually a reasoned decision from before that we've had in the pipeline. So that's kind of where I would kind of pitch that at that point. The other bit, just before we finish this point, if it was someone who was younger and it's not like that important, like they're not an athlete, it's not their job, but like you've got scope to maybe they're doing ballet 5 days a week or whatever, but they're also in school, then I'm just kind of a bit more pragmatic and saying, look, let's just try and fix it first before you go back. And that's usually just a little bit easier with a parent who's, well, I say easier, some of them aren't, but you know, on the whole it is.
And when you're going through in your mind what is valuable from a physio and rehab perspective with these patients that are presenting with hip dysplasia, what are you thinking of are the big rocks from these are the tissues I need to load, these are the positions, these are maybe the things I want to pull back from? What's going through your head during the start of a plan of care with a patient?
Honestly, like from a rehab perspective, it's probably will surprise you to hear this, but like the psychology for me is like probably the top, because I think the rehab that I'm giving someone to do exercise wise, I need them to be able to do it. And for someone who's been in pain for 5 years or 4 years or whatever, like I don't want to just give them exercises that they don't understand why they're going to do them, but also like that aren't going to give them the additional like confidence. Like the confidence and the reassurance is so important with these patients. They really need to kind of felt listened to. They need to kind of felt appreciated with the level of pain and accepted, you know, the fact that they're dealing with pain for so much time. And the exercises for me at that early point in particular, it's not about like, I got to load the glutes and I've got to load your adductors. We'll do that. You know, anyone can give exercises, but it's about choosing the right exercises that are going to be suitable for that individual's function, what they want to get back to, what they can tolerate, what they can't tolerate, but to really empower them to do them. And then when I meet up with them in a month's time, they say, look, I've done it. I feel better. I feel stronger. And actually, like, I feel a lot more confident. And often what I hear is they say, oh, you listen to me, and like, I finally understand like what it is that I have to do. And then as things progress, then we can start to put a bit more of a rehab hat on in regards to how much range of movement are we going to move into for kind of in a sagittal plane or in a frontal plane, or how much do we need to, for this block, focus on the deeper stability components. And then I say to them, look, I'll do the thinking. Like, you don't need to worry about it. Let me think about what exercise I'm going to give you, what I need to make sure that you can just do them. And as things progress, and it, from a physio's perspective, it might be that you give for the first block some fairly straightforward exercise. It might just be you give them isometrics and a functional thing to do, but that they can do. And then as things progress, then you start to think, right, if I want to work on stability, well, stability isn't just working on standing on a Bosu ball. You've got to think, well, your deep rotators, they stabilize the joint. The adductors, they give the stability to the joint. We need to kind of focus on, well, like, what are the anterior structures, like the iliopsoas, that can give stability. So then we start to think about those components from a bit more of a rounded rehab approach. But you don't want to do that to start with, because it might be too much. And if it's too much and it flares up, normally what happens is they don't come back, and then they'll go on to the next thing, and then they'll try something else. And that's kind of the kind of cycle we get into.
Yeah, setting those expectations early on and creating this reassurance and resilience by building these wins over time, with not doing too much too soon and making their symptoms even worse when, like you said, it's been this progressive onset and worsening where there's just probably a lot of uncertainty and frustration that they're experiencing. If their physio flares them up consistently because they're trying to do too much, then that's not helping at all. So is there anything that you noticed either in your own practice that you've evolved over the time you've treated these populations, or that you've noticed with other clinicians, where these are just things that are common mistakes that, and you may have touched on some of them already, but things that you think we should address and discuss, of things that shouldn't be going on, or things you'd recommend we avoid?
Yeah. Okay. So look, I think if there's one thing that I want to touch on with this, then in that case, it is from a clinician's perspective, and from a rehab approach, don't put all your focus on someone's tight hip flexor. Like, I guarantee you, with someone who has hip dysplasia, they will present or respond or give you some sort of insight that they've got a tightness at the front of the hip. A tightness at the front of the hip, or that perception of someone having a tight hip flexor, is used in this population. That's a symptom. That's not the main cause. Now, don't get me wrong. It's not to say that we wouldn't treat the hip flexors in some capacity, but stretching it, pulling it, doing deep frictions and all this release stuff, that ain't the answer. That's not what we're trying to do. That's not where our focus is. What we need to do is understand why that's happened. Why is it feeling stiff? Like, why is it irritable? Is there a tendinopathy, or an irritated tendon? Why is that the case? What can we do to load it up to kind of reduce that tolerance, but then also address the root cause of the hip problem as well, not just the kind of extra articular things that we would discuss there. And I think that's the biggest error that I see, unfortunately. The group question that I said at the beginning, like, how many people have seen hip dysplasia, and they say, like, a lot of people say no. I guarantee you, like, the tightness of the hip flexor, or an irritable hip flexor, everyone will put their hand up. But unfortunately, that's just like one of the masqueraders that will be there alongside this hip condition. Same as, the location of where the symptoms are. Location doesn't tell you enough. So if you've got someone that comes in and they're telling you they've got pain at the side of the hip, and they're saying, oh, I was told I've got bursitis, can you kind of do some acupuncture or whatever? And you're thinking, well, I could, but one, bursitis of the greater trochanter isn't that common, and two, when it is there with GTPS, it's normally in a menopausal middle-aged woman, not a 20-year-old female who hasn't gone through those changes. Do you know what I mean? Like, so I think those are where the pitfalls come. It basically comes down to an inability to answer why you're giving someone the rehab exercises that you're giving them. That's probably in a nutshell.
If a patient asks you, why are we doing these stability or strengthening exercises, what would you recommend be a educated explanation without being, I don't know what the right word is, not lying, but what is going on when you're exercising and loading? Is there actually structural change that is occurring? Are you just dampening down the symptoms? Like, what are you explaining as like the benefit of doing this thing?
Yeah, that's good. While we were talking about the last point before, and I was thinking actually that we hadn't mentioned something, and I'm pleased that you asked that. With all of the stuff that we've just discussed, right, and we're talking about like they've walked through the door and we've got this like hypothesis Royal Rumble that we're trying to figure out, and then by the end of it we might have sussed out one or two that we think is going on, hip dysplasia being one of them. At that point, what you don't want to do is bombard the patient, right, with all like, don't get excited and then be like, oh god, okay, so right, here we go, right, so hip dysplasia, and then because then they'll leave and they'll think, crap, my hip's unstable. Like that's all they will hear. Like, I don't know what the research is. It's like the kind of patients take away like X amount of like information that you give them. So personally, what I try to do now is avoid it. Like I try and not put too much focus on it because I know what we're dealing with, and I'll say to them, look, I'm a bit vague. I'm like, oh, I feel like what we're going to do now is just focus on trying to rehab your hip. All right. And then like I kind of leave it at that. And if they start asking me questions, some want, don't get me wrong, some want like the nitty gritty. And I'm happy to discuss that with them. My concern is, one, if you start going too deep in the appointment, they won't retain it. I'm worried about what they've retained. And even if I send them stuff to read, then they'll start kind of wanting more and they'll get a little bit more stressed by it. So I don't want it to be kind of from a nocebo perspective. But if they want to know, we'll go through it. The other thing, though, is if, for example, I've got a patient who, like, let's say, for example, they come in and they're like, oh, I want to have like physical treatment. I want to do like cupping and the scraper thing or whatever it is. I don't do that, but like, the like the knife and fork situation, whatever. I don't know what that is, but and yeah, massage. I'm like, fine, but I want to, like, I think you'd benefit from doing this rehab because this rehab will build up the tolerance of your hip to do the functional things that you can't do. You're telling me you can't walk, that you can't sit, that you can't go for a hike. Like, I want to give you stuff that will help you get towards that. The other stuff might help for your pain, but it won't physically make you more resilient. So I wouldn't want to go into too much depth with the patient. But where I would want a clinician to have that understanding is if you're in your clinic room with your patient and I come in and I say, as a peer-reviewed assessment, why are you doing that? Like, you can rationalize it. But as soon as you start rationalizing it too much to the patient, like, it just makes them, from my experience, they kind of get a bit more confused and they'll probably glaze over and not listen anyway. So they don't need to know how clever you are. Just get them better. That's all.
What about the other side where they're coming in with a referral from an ortho and they've had imaging and they've maybe had some nocebic language thrown at them and you're trying to like pull them off the ledge? How do you go about that process where, you just discussed if they don't have this diagnosis initially, but this is likely what's going on, you're being generally vague, you're providing all these other things, but it's not the nitty gritty. What happens when they're coming in with a lot of fear and anxiety and they've been told a lot of things already?
Look, I think definitely be professional. Like, I think there's no value in just slating other clinicians and saying, oh no, they're talking rubbish or that's wrong. I would probably say, like, that's fair. It's good to know that's what you've been told. Like, my experience with this is slightly different. Like, if we're talking now, like, obviously the condition is still there. So let's have a fresh approach to how we're going to address this. And this is kind of how I want to deal with it. And I'll try and kind of like de-escalate and demedicalize it a little bit, just so that, and treat the person. A hip is attached to a brain and a person, right? So just deal with like Joe, Susan, Adam, whoever, like, deal with the person themselves and just listen to them. That's why I said at the beginning about, like you said, what's the most important initial stage of rehab, and the psychology of it is so vital with these patients in particular. So if they come in and then they're being told, oh, like I've got a like unstable hip, I'm going to need a hip replacement in 2 months, so this isn't even going to work, then I'd say, well, look, actually, and I'd start talking about like the asymptomatic findings and how it could be normal and how we can get a good outcome, but in a professional way, not to kind of say, oh no, they were wrong. I'll just say, understand they've probably kind of got good intentions. They've explained in a certain way, but also there's like a different side to how you can perceive and listen to this information. And I'd probably go through it with them in that light and just try and reassure them. But also there's a limit. Like, you don't want to just blow smoke up their ass and just tell them what they want to hear and it's not true. You've got to have that balance of say, like, well, this could be it, but also I kind of get that if it's not getting better, we have this potential. And those are kind of conversations that you would need to have and just be transparent but pragmatic.
Is there anything else that you want to touch on that we haven't already discussed about hip dysplasia?
No, I think these are, and I'm really, once again, like I really value and thank you guys for having me on, because I think this is like something that we really need to get better at as a population, like clinical, and it's not just physios, osteopaths, doctors, like everyone. Just I think we need to have it on our radar. But the second it's on your radar, we're already winning. And I think like that's things like this are really critical. Unfortunately, like it will take a little bit of time. And I think as education progresses and people are a little bit more aware, I think we'll kind of like find that everything that we've just discussed now becomes the norm, like it is with your lumbar spine patients and the quarter recliner, that you can rattle off the red flag questions and your anatomy and all of that stuff. Most clinicians know because it's ingrained in your brain. I think this is one of those things that we just need to kind of like get ingrained into our brains a little bit as well. And I think we're getting it. We just take a little bit of time. But with studies like the one we discussed coming out, I think there's real positive hope to kind of improve on that.
Agreed. Yeah, I'll link the Evans study below and your information and the courses as well. Is there anything else that you have resources wise that you'd recommend people look into on this topic? Or do you think those are really good starting points, your resources and the Evans piece?
Yeah, well, one of the things I've started to do now, actually, as of this week, is I've created a YouTube channel specifically that's patient-centric, because what I wanted to do, all my referrals come from physios, and all physios I speak to say, all my patients I speak to that come from that point say, they've directed me to your Instagram, and I think that's great. Like, Instagram is great, and I'm really thankful because we get a lot of kind of footfall through there. But for slightly longer form content, and I'm talking like 7 minutes. You post something on Instagram for more than like 5 seconds, no one sees it. Like, so unless it's like someone doing something weird, like it doesn't show it to anyone. So now on YouTube, I thought, right, let me create these videos that are, what would I search for as a patient? I'd go on YouTube and I'd search for why does hip dysplasia hurt? And I'm starting to create videos like that someone can just watch it, listen to it, and just get it, and not have to worry about all like the medical jargon and stuff like that. So I think that's a growing source outlet that I'm going to be kind of building a lot. So I would say that, and also my Instagram and my website would be the kind of place that I would direct people to. For me, I don't know like where other stuff is, but that would be my starting point.
Awesome. We will link all of your information and the YouTube videos. Do you have any already out, or is this in? I
posted my first one yesterday. Yeah, I posted, which was what is hip impingement and why does it hurt, or something like that. And I've got one coming out tomorrow, which is top 7 signs and symptoms of FAI syndrome. So yeah, there's plenty more coming. I've got like a list of about 30 videos that I need. Now I'm doing YouTube. Now I realise it's bloody long to edit. So I've realised. So I don't know how like you guys do these long ones, but if I can keep it to about 5 or 7 minutes, the editing won't be that bad. So, but yeah, there's plenty more to come.
Yeah, shout out to Tony, the hidden man behind E3 editing, because he just will hunker down and do it over the course of multiple days, and that's all he's focusing on. And a lot of people don't want to do that. So props to you for trying to tackle that as well.
Yeah, for sure. Well, I appreciate you having me on, Chris. Thank you.
Yeah, thanks for coming on for round 3, Mehmet. We'll call it there.
Cheers, mate.